Chapter 22, Antipsychotics and Anxiolytics. Psychosis. This is the loss of contact with reality. In theory, it results from an imbalance in neurotransmitters dopamine within the brain. It's characterized by things like a difficulty in processing information, disorganized thoughts, incoherence, distortion of reality, delusions, hallucinations, catatonia, and even aggression and violent behavior. Schizophrenia. This is a chronic psychotic disorder that usually occurs in adolescence or early adulthood. And it has several categories of symptoms, everything from cognitive to positive and negative symptoms. This is something we're going to talk a lot more about in mental health next term as well. Positive symptoms are something that are there that should not be there. That'd be like hearing voices or visual hallucinations. Whereas negative symptoms are something that are not there that should be there, such as things like lack anhedonia, an inability to feel pleasure, a lack of motivation, a flat affect. The cognitive symptoms are things like disorganized thinking, difficulty remembering, and a decreased ability to focus attention. Positive symptoms are an exaggeration of that normal function, delusions, hallucinations, incoherent speech, paranoia. These are things that are present that should not be. Versus negative symptoms, these are poverty of speech, that blunted affect, poor self-care, social withdrawal. To treat this, we have a category of medications called antipsychotics. They treat the mental illness to help improve thought processes and behavior. And most work by blocking the dopamine receptors within the brain. And they also come in two major categories. Those are the typical or the traditional medications that are used to manage positive symptoms. Then we also have the atypical that manage both positive and negative symptoms. Typical groups of antipsychotics would include things like phenothiazines that block norepinephrine, causing a sedative and hypotensive effects, or non-phenothiazines that block only the neurotransmitter dopamine. On the other hand, atypical antipsychotics treat schizophrenia and other psychotic disorders by blocking both dopamine as well as serotonin receptors. The adverse reactions of antipsychotics are going to be things like extrapyramidal symptoms, acute dystonia, akathisia, tardive dyskinesia, and neuroleptic malignant syndrome. For our typical antipsychotics, we have several phenothiazine groups, such as chlorpromazine, perfenazine, and thiordazine. And you'll notice that they all have a similar side effect, adverse effect of those extrapyramidal symptoms. For our other phenothiazines within the typical class would be fluphenazine, and it works to block dopamine receptors within the brain, as well as managing symptoms of psychosis during schizophrenia. It has side effects like dizziness, headache, blurred vision, and weight gain, in addition to dry mouth, urinary retention, seizures, blood dyscrasias, and again, that extrapyramidal symptoms. Within our non-phenothiazine class is one you've probably heard about a lot, Haldol, haloperidol. This alters dopamine effect by blocking dopamine receptors, and it treats everything from psychosis, schizophrenia, as well as Tourette syndrome. It also has a lot of contraindications, such as narrow-angle glaucoma, dehydration, central nervous system depression, cardiovascular disease, hepatic damage, and blood dyscrasias. Some side effects would include, again, drowsiness, headache, tachycardia, orthostatic hypotension, seizures, urinary retention, constipation, erectile dysfunction, and extrapyramidal symptoms. When giving both phenothiazines as well as non-phenothiazines, we want to carefully assess the patient's vital signs and get a thorough, accurate health history. We also want to carefully assess how effective these were. Is the patient able to communicate coherently? Will they appear calmer? Have we diminished their hallucinations? Again, remain with the patient while this medication is taken and swallowed. Carefully observe the patient for any hint of adverse effects, and inform the patient that the medication may take up to 6 weeks or longer to achieve that full clinical effect. And that's another thing you're going to see with a lot of psychiatric medications, that some of them can take several weeks to begin to take effect. In the case of atypical antipsychotics, these are effective in treating both positive and negative symptoms of schizophrenia, and also less likely to cause EPS or tardive dyskinesia. And that's because they work to block the serotonin and dopaminergic receptors. Side effects are things like drowsiness, headache, an unsteady gait, insomnia, depression, weight gain, and even diabetes. Our first atypical antipsychotic that we'll discuss is clozapine. This treats severe schizophrenic patients unresponsive to traditional antipsychotics. It has side effects such as dizziness, drowsiness, insomnia, tachycardia, constipation, leukopenia, tremors, and occasional rigidity. The next would be risperidone or Risperdal, and it's a drug you've probably seen given a lot. It's used to manage the symptoms of psychosis and treating both positive and negative symptoms. Side effects would include things like dizziness, drowsiness, appetite stimulation, constipation, anxiety, weight gain, insomnia, and nausea and vomiting. Aripiprazole. Works to manage symptoms of schizophrenia, bipolar disorder, autism, depression, and Tourette's. It causes everything from the drowsiness and dizziness, as many of our other antipsychotics, to anxiety, agitation, blurred vision, impulse control symptoms, tachycardia, erectile dysfunction, and fatigue. Anxiety disorder. Comes in many different common classes of anxiety, everything from general anxiety disorder, social anxiety disorder, obsessive compulsive disorder, panic disorder, and post traumatic stress disorder. It's also characteristic of excessive anxiety, sweaty palms, pacing, restlessness, palpitations, tachycardia, dyspnea, and even difficulty concentrating. To treat anxiety, we have anxiolytics. First one we'll discuss is lorazepam. This inhibits the GABA neurotransmission by binding to specific benzodiazepine receptors. Treats anxiety, seizures, insomnia, sedation induction, and status epilepticus. It can also have side effects, drowsiness, dizziness, headache, confusion, bradycardia or tachycardia, depression, dependence, seizures, and suicidal ideations. When discontinuing, you want to gradually decrease the dose over several days, as withdrawal symptoms may appear slowly in 2 to 10 days, and these withdrawal symptoms could last several weeks as well. In the case of short-term withdrawal symptoms, we're going to be looking at things like nervousness, agitation, insomnia, tremors, sweating, while long-term withdrawal symptoms like paranoia, delirium, tension, seizures, and status epilepticus. When giving benzodiazepines, we want to carefully watch for any indication of suicidal ideations. Get a thorough history of the patient's anxiety reactions, and also determine the patient's support system. We want to carefully monitor the patient's vital signs, look for any indication of side effects or adverse effects. Encourage the family to be supportive of the patient, and advise the patient not to drive a motor vehicle or operate dangerous equipment when taking this medication. You should also warn them not to consume alcohol or combine with any other CNS depressants. Next up would be buspirone. This binds to serotonin and dopamine receptors, and again has the effects of drowsiness, dizziness, ataxia, headache, blurred vision, nausea, edema, erectile or ejaculatory dysfunction, and extrapyramidal symptoms. For our first practice question, the nurse realizes more medication teaching is necessary. When the 30-year-old patient taking lorazepam states which of the following: A, I must stop drinking coffee and colas. B, I can stop this drug after 3 weeks if I feel better. C, I must stop drinking alcoholic beverages. Or D, I should not become pregnant while taking this drug. That answer is going to be B, I can stop this drug after 3 weeks if I feel better. For practice question 2, a young woman is being treated for psychosis for flufenazine. Which sign would indicate the need to add an anticholinergic to the patient's medication regimen? That be A, a decrease in pulse and respiratory rate, B, facial grimacing and tongue spasms, C, an increase in hallucinations, or D, a decrease in the patient's level of orientation. And that answer is going to be B, facial grimacing and tongue spasms. For question 3, a patient on risperidone may be at increased risk of injury due to which of the following? That be A, increased potential for aspiration due to sedation, B, increased risk for falls due to orthostatic hypotension, C, an increased risk for infection due to neutropenia, or D, an increased risk for suicide due to changes in thought processes. And that answer is B, an increased risk for falls due to orthostatic hypertension. Safety is always a top priority. For question 4, assessment findings for a patient with neuroleptic malignant syndrome include which of the following? A. Bradycardia, B. Hypothermia, C. Muscle weakness, or D. Rhabdomyolysis? And that answer is D. Rhabdomyolysis. And that's also a topic we're going to discuss much more when we start talking about statins. Question 5. Which statement by a patient indicates that more teaching on a phenothiazine therapy for the treatment of psychosis is needed? That be A, it might take 6 weeks or more for the drug to take effect. B, I'll get up slowly from a seated position. C, when I start to feel better, I'll cut the dose of my medication in half. Or D, I'll avoid exposure to direct sunlight. And that answer is C. When I start to feel better, I will cut the dose of my medication in half. And for our final question, a patient has been diagnosed with neuroleptic malignant syndrome. The nurse anticipates the administration of which medication to treat this patient? That be A, dantrolene, B, tetrabenazine, C, propranolol, or D, lorazepam? That answer is A, dantrolene. And these antipsychotics especially are a category we're going to be talking much more in depth when we get to mental health. But anyway, that's all we got for this chapter. I'll see you in the next slides.